Friends, I think it's the time to start the final round of today because we all want to be in time and we want to end this session at 8 o'clock as promised. So first thing, administrative thing, I will pass you the list to write down your names. As Professor Bornstein says, write only your names and not your friend's name. And then it's my great pleasure to introduce the first speaker of this evening, who is Professor Amos Korczyn, that we all know so well. He's from Tel Aviv University, and he is a great friend of the Romanian neurology. He is also the inventor of CONI, of Controversies in Neurology Congress, that we enjoyed, many of us, for such a long time already. He is not only a neurologist, but a neuropharmacologist, let's say, as formation. And he had a great contribution and has a great contribution in neurodegenerative diseases such as Alzheimer's disease and Parkinson's disease. And he will make us the favor to give us actually two presentations. First is linked to mild cognitive impairment, and then we'll be presenting a series of case presentations. Professor Korczyn, thank you for being here as every year, and we are indebted to you. Thank you.
Thank you very much. It's a pleasure to be here again in Euphoria. I don't know how many of you have been here before. How many of you have been here before? 1, 2, 3, no. 2 only? Very good. But plan on coming again because it's a nice place, as you have seen already. Several of you are still out there and enjoying the beautiful weather that has been arranged for us. So we should really enjoy the opportunity to be here and to discuss with you several of the topics that are coming here. It's always very refreshing to talk and to discuss with young colleagues and to hear their impression. So I would really would welcome any suggestions, any comments, any questions that you have. Please don't be afraid. Don't be ashamed to ask questions. If you don't understand something, it means that several others do not understand it. So rather than asking your friend or commenting to making remarks there, please say it aloud, and we are going to discuss it. So mild cognitive impairment is a topic that was assigned to me today. Everybody knows what mild cognitive impairment is? Everybody fell asleep. Who knows what is MCI? Nobody knows what is MCI? I can't believe it. You don't know what is mild cognitive impairment? Come on, you, lady, what do you think is MCI? Can you speak up? At my age, we don't hear that well. So it's a condition where?
I don't know, MCA above 26, maybe?
Now,
There's no links to MMS.
No, not related. No.
Talk to the microphone. Say it again.
I thought it's regarded to the MCA score, like above 26, or it's a cognitive impairment, not dementia, but beginning of dementia. No.
Okay. Anybody has another view? What is MCI? Come on, the friend next to you. What do you think is MCI? Come on, take the microphone. Don't be afraid. It doesn't hurt. What is MCI? Mild cognitive impairment. If you don't answer, I would think maybe you have MCI.
No.
Come on, wake up.
I don't have a different opinion.
You don't have a different opinion. Okay, next one.
Cognitive impairment, MS.
Yeah.
MSEA. Okay.
All right.
Between 23 and 26, I believe.
Yes. Okay. So what is underlying this is the subtext of what was mentioned here, is that we are all afraid of Alzheimer's disease. Well, you know, you're too young, but people of my age, we are all afraid of developing dementia, and of course this is because we see it not only in our patients but also around us, our friends, family members. So it's very alarming. So of course we think about it and try to think what can we do against it. And we also know that that Alzheimer's disease or dementia does not usually develop overnight. It's not that now I am okay and tomorrow morning I will wake up demented. It's a slowly progressing disease, very slowly progressing. So, but the important thing is that we know now that the changes that in the brain that cause Alzheimer's disease also do not develop overnight, but take many years, maybe 20 years, maybe 30 years or more to develop. So if somebody within, you know, maybe not your age already, but at the age of 40 or 50, if they have an accident and die in a road traffic accident, there are already signs of Alzheimer's disease in many of these people. So it's a slowly evolving, accumulating process. And if this is so, then this is very important because it says that if we can identify these people, we can perhaps intervene and prevent the development of dementia later on. We don't yet have this magic bullet that will stop the degeneration, and we therefore cannot use it. But supposedly, with all the research that is being done, this is something that is going to come on, and it, you know, I'm not sure whether during my life, but definitely during your life. So this is something that we should really think about and try to identify who is at risk and what to do about it. So we have to know who is at risk. So what is mild cognitive impairment? How do we define this? So there is a group around the Mayo Clinic led by Ron Peterson who defined it in this way. So this was a committee, and the committee set 7 days and 7 nights and thought about it and discussed it and came up with the definition and said, this is what is mild cognitive impairment. So of course they say there must be a complaint. If the person does not complain, then everything is okay. And the complaint should be objectified. It's not just a subjective feeling that I say that I have some problems. It's a person must be must undergo tests, and the test should confirm that these complaints are real, that the function is below the age normal, below what is normal for this age. And the most likely symptom is, or complaint, is that the person does not remember. This is memory impairment. And for this type of complaint, person must be otherwise okay. So other cognitive domains should be normal. The activities of daily living should be normal. Instrumental activities of daily living should be normal. So just this amnestic way, amnestic problem. And of course, Ron Peterson and his friends who set, as I said, 7 days and 7 nights and had deep thought about it, were not the first one to recognize that dementia does not develop overnight. And there is a lot of names before, and maybe you will see them somewhere in the literature. So when I was your age, which was, like, let's say 40 years ago, when I was already a neurologist and interested in cognition, there was this concept of benign sensate forgetfulness, led by Kral, who was a Canadian psychiatrist, and he says in old age, people do not function as well as they did during young age. We don't run as fast as we do. There are many things that we don't do as well as before, and this also affects the cognition. And since I don't run as fast as I could 40 years ago, this does not mean that I will be bound to a wheelchair tomorrow or next year. I will be even slower, perhaps, but not much slower. So I will still be independent, and this is what he called benign senescent forgetfulness. So it's a benign form of forgetting, not leading to dementia. And he followed up these people, a group of people, for maybe 5 years, and this was his conclusion. But had he followed them up longer, he would see that many of them, after many more years, after several more years, would develop dementia. So it's not always benign. So he was wrong in the assertion that it is a benign condition. Then came another group who spoke about age-associated memory impairment, AAMI. It's the same thing. They say, well, this is aging. What they did not say that it's benign, but they say this is an aging phenomenon. The brain ages like any other organ in the body. And this, of course, can affect memory, but also other functions. So they also coined another term, which is age-associated cognitive impairment, not necessarily memory. For example, executive functions can be impaired without memory being very much dysfunctional. Then there is this other term called subjective complaints of memory deficit. So here we spoke only about subjective without an objective phenomenon. The question is, if I am going to develop dementia, who is the first person who will recognize this? Would it be me, or would it be my wife or my colleagues? And it may be different for different professions. So maybe for me, it will be people who are stimulating me intellectually, and I have to respond to their questions, and they will notify that I'm not doing it that well. But for a person who does a manual job, perhaps it will not be that easy. This person himself or herself may feel that there is something wrong, but it will not be obvious to others. So whether it is subjective or whether it's objective depends also on the environment, on the condition. The Canadians came with another term called cognitive impairment, not demented. So there is cognitive impairment, maybe in memory only, maybe in other functions, but the person is not demented. Others say that instead of calling it SIND, we should call it SIND with a Y at the end, meaning cognitive impairment, not demented yet. But in the future, the assumption is that some of these people will develop dementia. Or questionable dementia, or minimally impaired, or incipient dementia, again, like Cindy, implying that there is something going on, and it is a problem that will come up, or very mild dementia, or borderline cases. So the definition of that is now prevalent, Peterson criteria of mild cognitive impairment, have limitations. So the definition is definition, but we must be aware that there are difficulties. For example, as I already alluded to, the fact that there are complaints does not mean so much. It's not objective. That's why we need the objective confirmation. Subjective means that I think so, but some of us tend to be complainers, and some people who have a headache run to the doctor, and some people say, no, it's not a matter to be worried about. Let's see what will happen. And the same is true for people with memory impairment. Some of them run to the physician earlier than others. Then Peterson demanded also, so the dependence on the complaints themselves is not sufficient. Then this group also demanded also that this subjective complaint will be also strengthened by complaints from people around this person, so maybe family members would note it. But again, these are not experts in the field, and we don't always can really rely on their responses. So then they wanted also, Peterson group, that there is dependence on cognitive tests. So there are cognitive tests, and as I mentioned before, these people, in order to make these tests, there should be memory performance below age-based reference normal. So what are these data that we get from the normal population? Well, you know, the normal population is not all the same. Some are better, some are worse. So if I develop cognitive impairment, it may not be that I will be picked up by the tests that are being done so early. Maybe because I have a mini-mental test, you all know, it goes from 0 to 30. Maybe those of us who are in this room score how much? How much do you think you score, gentlemen?
I hope I score 30.
30. I think that you are above 30. I think there is this ceiling effect. I think it will, even if you don't function that well on a certain day, you will still be 30. So we have quite a reserve. So it's not always very good to conclude based on this test. What would be better is if I would compare if somebody could compare my results now in a neuropsychological test to my baseline from 10 or 20 or 30 years ago. But this would be the best to show whether there was a decline. But of course, unfortunately, we don't have this data. So this is a problem. Which tests to be used? So there are many tests, and of course, mini-mental is one of them, and you know about mini-mental, and you know about MOCA and Addenbrook and many others. So the committee did not decide what is the real test that should be done, and if this is so, then somebody goes to one person, they will get one report, and they go to another, they will get a different report. So I'll give you an example. So just a few months ago, a few days ago, at home, an older person came to my clinic and said that he wants to know what's going on in him because he doesn't remember that well and forgets something from time to time, not too bad, but he's worried. So he went to his GP, and the GP examined him and said, "Nah, this is nothing. This is just your age." So he wasn't that happy and went to a neurologist, and neurologist examined him deeper and said, "Well, you have MCI. You have mild cognitive impairment." So he got confused. If you go to have a second opinion, this is a mistake, because if you don't believe the first report and you go to somebody else, if he gives you the same result, then you wasted your time and money to go to to have a second opinion. And if they gave you a different report, then of course you are confused. What do I do now? Is this? Is that? So what do you do then? You go to a third opinion. So he came to me for the third opinion to ask me what does he really have. So I will tell you about this a little bit later. So of course it's not written there in the definition, but of course the idea is that the memory complaints should be of recent origin, should not have been there forever. The complaints should be persistent. It's not just I didn't remember something yesterday, but it had to be ongoing for a longer time. So there should be, as they mentioned in the committee, objective cognitive impairment, normal ADL, and otherwise normal cognitive findings. And we should exclude depression, because if the person is depressed, of course they don't function well. So this is a very important thing. If they are under psychosocial stress, or drug or alcohol abuse, etc., all this should be taken into the history, and we should. And if this happens, then of course the patient's this person is not expected to have normal cognition. As I already hinted, there is another problem of this definition of MCI, and this is the extremes. So there is this overlap with, on the one hand, with worrying well. So maybe I went to my doctor because I don't remember, I complained I don't remember well, and the doctor who knows me, who is my friend, tell me, yeah, but you've been complaining of different problems all the time. You're a complainer. So now you can complain about this. So this is what we call worrying well. Person who is well, no problem, no objective problem, but complaints. And the on the other side, the other extreme is what happens to these people when they develop dementia. Of course, those who develop dementia do not develop the dementia overnight. So if they come to a doctor after 6 months for a recheck, and the doctor gets a history and makes an examination, say, yeah, you have mild dementia. Of course, this is not started on that day, or in the previous week, or in the previous month. We don't know when it happened, so it doesn't happen overnight. So again, there is a problem in definition on the two extremes. But overcoming this problem, we should ask ourselves whether what is really mild cognitive impairment? Is it a true disease entity? Because the way we talked about it now, it's more like a syndrome. This is a phenomenology which tells us what it is. So if we submit people who fulfill the criteria of MCI to, let's say, MRI test, we can see that many of them have hippocampal atrophy. So this suggests that they have underlying Alzheimer changes. And indeed, about 70% of them would develop dementia, Alzheimer dementia, within 5 or 6 years. If they have undergo autopsy later on, it turns out that many of them do have Alzheimer pathology, but nobody has pure Alzheimer disease. Pure Alzheimer disease does not exist in old people. Pure Alzheimer disease exists maybe in people with early onset dementia, but people of my age, people who develop dementia, already develop many changes in the brain. So all of us has some vascular changes, not severe one, we'd never had, not really a stroke, but we can see changes on the MRI and definitely at autopsy of vascular changes in the brain. So therefore, the implication is that mild cognitive impairment is heterogeneous, and I'll come back to this, and I think that this is the most important take-home lesson from this lecture, that MCI is not a disease. It's a syndrome, and the syndrome is heterogeneous in its origin and its phenomenology. And the other important thing is that those who fulfill the criteria, if you go and examine them again and again and again, several of them, maybe 1/3 of them, will not develop more severe cognitive impairment. In fact, some of them regress to normal. So you tell them come back next year, and they come back the next year, and you ask them how you're doing. So very well. So you ask, so what about your memory? Is it? Said, well, I had this problem before, but I don't have it anymore. I'm functioning okay. So many of them will not develop any cognitive impairment. So it might be a benign condition. It's not always necessarily going on to develop dementia. And as I said, this is a heterogeneous disorder. So there are those people who say, I have memory problem only. And in those, we think maybe it's the prodromal phase of Alzheimer's disease, because Alzheimer's disease, as you know, starts with hippocampal changes, which are associated with memory impairment. What is the typical memory impairment in Alzheimer's disease? Who can tell us? What is the typical? So what about you now? Tell me. What is a typical? Come on. What is a typical? You want me to come to you? Come on, stand up. You don't turn your head. You. What is the typical amnestic form of Alzheimer's disease? You don't know? Anybody knows? What is the phenotypic picture of patients who have early Alzheimer's disease? What do they forget? So their problem is with episodic memory. So if I will meet one of a person whom I met at a party last night, they will not remember that they have been to the party. The episode is lost. But most people who come with the complaints of MCI do not have this complaint. They say rather, well, you know, I go to the kitchen and I don't remember what I am there for, what I came for. This is not a hippocampal function. This is something else. This is a different cognitive impairment, different mnemonic difficulty, which is more executive, more frontal lobe dysfunction. It's like people who have other forms, even in young age, problems with memory. This is what they complain of. But if they have amnestic, this type of amnesia, that they don't remember things that happened last night, or they read a book and now they don't remember anything about, or even reading this book, or what happened in this book, then this might be what we call amnestic MCI, and this may be the presentation of Alzheimer's disease. But in others, as I said, there is different forms, and this may be due to vascular changes in the brain, or mixed changes, I said, because many of us have mixed pathology, and so on and so on. But the important thing is to identify those people who have treatable causes. Treatable causes, and we'll come back to that, because not everybody who is 70 or 80 years old and comes with cognitive impairment, let's be it amnesia or anything else, necessarily has Alzheimer's disease. They can have treatable causes, which are very important to identify and to treat. So there was an attempt to say, okay, if it's memory, it's going to lead to Alzheimer's disease. And I told you what are the difficulties here, that it's not all types of memory, but only amnestic memory. Then there are those people who had language problem, difficulty in finding words, and going on to develop more and more difficulties. Then maybe this will have frontotemporal dementia in the form of primary progressive aphasia. Or if they have executive problems, this is, again, could be either vascular changes or frontotemporal dementia or initial changes of Parkinson dementia. Or corticobasal ganglionic degeneration, they have practice problems, they cannot function, do things right. And or REM sleep behavior disorder associated, which will lead us to think that they have DLBD. But actually, this is more theoretical. In practice, it doesn't work that well. So the early impairment in Alzheimer's disease, I mentioned, encoding new episodic memories, but many people with proven post-mortem Alzheimer's disease have deficit in attention or in semantic memory or language difficulties and so on. So it's not clear-cut that the attempt that we would like to have, that a disease entity has its own pathology and its own specific cognitive changes, does not work in reality. So let's think about the etiology, and I want again to stress the fact that it is very heterogeneous. So here maybe on the right are the things that we've talked about before: Alzheimer's disease, Parkinson's disease, or dementia with Lewy bodies, vascular dementia, frontotemporal dementia, and I didn't mention, but of course you are aware of normal pressure hydrocephalus, which can also start with the cognitive impairment. But let's not forget the psychiatric part. Let's not forget the depression or anxiety, and in more severe form, post-traumatic stress disorder, which also can manifest in many cases as memory impairment. So this is very important to differentiate, because depression and anxiety are treatable lesions. So it's very important to identify them. And then there are the toxic causes. So benzodiazepine. So if the person was examined by me and I wanted to have a neuropsychological test on him, a longer battery, and they send him, I tell him, come tomorrow, the neuropsychologist will do the test, and they don't function well on this test. Maybe I would inquire and find out that what is causing it is the drug that they took, the sleeping pill that they took the previous night. So it depends what are these drugs that they have been taking. So if they took a short-acting benzodiazepine like bortizolam, it's a very short half-life of maybe 2 or 3 hours, then that's not a problem. But if they took Valium, diazepam, which has a very long half-life, they would wake up in the morning, as they do every day after they took diazepam the previous night, and say, I slept very well, thank you, Mr. Valium. But actually they do not function optimally. It's like a person who has been drinking alcohol at a party, like one of you, and you came out of the party and you wanted to drive your car. And of course, although you think you're okay, that you have recovered, the facts are, and can be shown, has been shown many times objectively, that you don't function at your optimum. And the same is true for this person who took a long-acting benzodiazepine the previous night. So you should inquire what is happening. And alcohol is the same thing. Barbiturates, for sure, many barbiturates have very long-acting. So I don't know how many of you still use or have your patients use phenobarbital. I recommend it to my patients not infrequently, and so on. And of course, also immune-related disorders. So MS. So we spoke about MCI in the context of older people, but young people with multiple sclerosis, we learn more and more that they also develop cognitive impairment beyond what is expected at their age. And this is something that we should think about, but also lupus and antiphospholipid syndrome can also manifest in mild cognitive impairment. It takes many years for these people to develop frank dementia, but mild cognitive impairment is not infrequent. So this is something else. And then there are also other things, so deprivation. So these people, older people like me, who we lose our hearing, we don't hear well, so it's not easy to communicate. And with whom do we communicate? So this person has been widowed and is now living alone. And there is nobody around them to take care of them or to talk to, because all their friends are gone either in some old age homes or died or whatever, and they are restricted in their surroundings. So this is social isolation or sensory deprivation, and all this also leads to reversible cognitive impairment. And hormonal Cushing disorder and dysthyroid is something that we should keep in our mind. And of course, we test for thyroid dysfunction. I will come back to this later on. And infective borreliosis, syphilis. Syphilis, 100 years ago, or at the turn of between the 19th and 20th century, was the most common cause of dementia. Neurosyphilis. And now, of course, it's all gone, and we hardly even test for syphilis in our clinic. But still, this can happen, and this is something that we should be aware of. Borreliosis and HIV are other examples. And of course, traumatic. These people, older people, tend to fall, tend to have a subdural, and subdural is also a possible cause, or intracerebral bleeding as well. So many etiologies. I give you this list, and of course we can add to this. The important thing is that we cannot say this person has MCI, we've confirmed it with our test, nothing to be done, we don't have a treatment for this for early Alzheimer's disease, forget about it, and too bad, but that's it. No, we should try and find out, and I will come back later on to this issue of what are the red flags that we should think about. So MCI is a condition. It's not a diagnosis. It's a condition. It's not a disease. And some people have always been mentally subnormal, and they are the same. So if they come at the age of 60 with the same mental retardation that was there before, but say that they complain that this is something new, they are not going to develop any further. They're stable. If they have depression or anxiety or any metabolic impairment, renal or hepatic or whatever, then these are potentially improving with the right treatment. But only those conditions which are associated with brain aging, these are the ones which are progressing, leading to Alzheimer or vascular dementia or any of the others that we have mentioned. So the conclusion so far, which is important, is whether MCI is really equivalent, identical to incipient dementia, and the answer is not always. Not always. In many cases, yes, but not always. So MCI is not a single clinical entity, and the term includes many forms, many etiologies, and different rates of evolution, and some people may not progress or even improve in follow-up. So the conclusion so far is that presence of unaccounted for MCI predicts the development of dementia, particularly if associated with gait impairment. I will mention this later. And patients with MCI, after excluding all these potential causes that we've mentioned, should be recognized and monitored for cognitive and functional decline due to increased risk of subsequent dementia. And what can we do about them? So firstly, the question is, what can we do to prevent dementia in general? So these are a high-risk group, but all the people of this age are at a risk. All of us who are beyond the age of 70 or so are at the risk of developing dementia. So what can be done about this? And we don't lift our hands and say, too bad, nothing can be done. No, a lot can be done. And the important thing is to identify what can be done. And, we say that dementia is now an epidemic. And if it's an epidemic, we should go and discuss it with epidemiologists. And the epidemiologists tell us what are the numbers. They count cases. But they also tell us about the risk factors. So the risk factors are some age, of course. Women are more likely to develop dementia. People who had head trauma are more likely to develop dementia. People who had depression are more likely to develop dementia, and so on. But these lead to us to think about drugs that may prevent dementia. So antihypertensive therapy. So hypertension is a risk factor for dementia, and of course, it starts like mild cognitive impairment, not dementia overnight. Hyperlipidemia or dyslipidemia are also important. So these are things that we can deal with. Now, many people who come to me with, let's say, mild cognitive impairment say, I ask them, of course, about hypertension. They say, yes, I have, but I take my pills and it's okay. I say, how do you know it's okay? Well, say, the doctor measured my blood pressure last time when I visited them, and he said it was okay. When was the last time? Well, it was 4 or 5 months ago. I don't remember that well. And how high was it or how low? I don't know. No, that's not a good answer. A person who's been identified or diagnosed with hypertension should measure their blood pressure routinely once a week. And when they come to the doctor, they should show him what are the values that have been measured. The same with statins, not every day, but so on. Deficiency of vitamin B12 deficiency is not uncommon in old age. Vitamin D is also recognized as important in this context, and treatment with vitamin supplements is important. Non-steroidal anti-inflammatory drugs is also relevant here. We don't know how important it is, but since many of these people take aspirin anyway to prevent vascular changes, so this is also important. What else can be done? So I mentioned before social interaction. Don't leave this old guy alone. And it's not enough that you call him, that his kids call him on the phone every morning to say, how are you doing, Dad? Or what's going on, Mom? No, they have to be incorporated in the community. Physical activity is important. We have data that people who are physically active are less likely to develop dementia later on. And this is across the board for all people, but definitely for those people who already have the warning signs of early cognitive impairment. Cognitive stimulation, what do you do? Well, you know, I heard that cognitive stimulation is very good, and since then, what I do is I do crossword puzzles every day. That's not good, that's not enough, that's not sufficient. What you should do is go to lecture. It's better still to give lectures, I can tell you, but at least listen to lectures and try to incorporate. It's important what the best, I think, best thing that I can tell my patients who have mild cognitive impairment is to write their history. Because, you know, your kids and definitely your grandchildren don't know anything about what happened to you when you were their age 50, 60, 70 years ago. Now you remember it, write it. So this means that they are going actively to be involved in writing, trying to remember, trying to phrase what is going on, recollecting and maybe correcting what they wrote yesterday. So this is really cognitive stimulation. I tell them it will help you, but your kids and your grandchildren will sometimes be sorry that they did not have time to listen to you and to hear what you did in your young age. At least they will have this document that you read. Treatment of coexistent depression. So many old people are depressed, and we don't know. They don't come and say, I'm crying all day. Maybe it's even not full-blown endogenous depression. Maybe it's subsyndromal depression. Still can be treated, should be treated. And other risk factors that should be dealt with lifetime changes. So smoking. And many of these factors that I've mentioned so far are important not only in old age, maybe even more important in midlife. So hypertension and dyslipidemia and smoking, a risk factor for future development of dementia 30, 40 years later. So it's people like you who should know what is your blood pressure, what is your lipid level, and not smoke. Healthy diet is important, and we speak about Mediterranean diet, but any diet that contains a lot of vegetables, a lot of fruits is good. Fish are excellent, and meat is not so healthy. Physical activity I mentioned, cognitive activity I mentioned. Alcohol abuse is, of course, dangerous, but mild alcohol consumption. So a glass of wine is good for you, and a glass of good wine is excellent for you. So think about it. Sleep hygiene. So many people have obstructive sleep apnea, and they don't care. They've always been like that. If it interferes with something, it's with the sleep of their spouse. This guy snores all the time. This snoring means that they try to recover from brain anoxia, brain hypoxia. And we have treatment for that as well. So again, take-home messages. The term MCI is of limited clinical usefulness. The diagnosis is arbitrary and it does not have a uniform underlying pathology. And the use of the term as a diagnosis is not productive. So this patient, this person who came to me for a third advice, the fact that they told him, somebody told him that they have MCI did not help him anything. He went back home, looked at the internet, find MCI, good, this is, I'm going to become demented tomorrow. No, this is not a diagnosis. Instead of telling him, giving him this name, tell him, look, you are now 75 or 85 years old, and you have already some signs of changes in the brain, and here's what you need to do. And give him this list that I gave you just now. And with this I will finish. I will invite you to this meeting, CONI, Controversies in Neurology. And in this meeting, we're always discussing this. We had it for 12 years. Many of the faculty here, including our chairman, have been faculty there as well. And we debate things in a pro-con divide. So, for example, we can talk about mild cognitive impairment. I could say mild cognitive impairment is not a diagnosis and should not be, the person who comes to us should never be given this specific term. So I will have 15 minutes to say more or less what I said here, and then somebody else will come up and we'll have 15 minutes to say why I am wrong, and after that there will be time for questions and comments, and then we'll come up with the vote and who is winning this game. So we have this 8 or 10 debates on dementia and parallel hall on stroke. Nathan Bornstein is leading this, on a different hall on Parkinson's disease, on different hall on multiple sclerosis, and so on. This is what is done for the weekend that we start on Thursday and finish on Sunday. So you're all invited, and to encourage you to come to this meeting. I think you have flyers here on the tables and outside as well. I will make a short quiz for you, and those who will, people who will win the quiz will have a free registration to this meeting, to our next meeting. So let's take an example of these MCI cases, and what do we do if you see a person who comes to you and says, and this is confirmed by the spouse, that this person developed quite significant cognitive decline within the past 5 months. Usually people who come with my conference say, well, you know, last year I also was not so good, and the previous year I was not also, it's going on, it's slowly progressing. But here there is something with a rapid progression. So anybody who wants to dare and say, what's going on? What can we do? What should we do? What should we look for? What is it that may cause cognitive decline of rapid onset? Anybody wants to come to Madrid? Come on. Come on, yes. I can't hear. Can we have the microphone? Here's the chairman coming. Chairman should sit here, in the front, not at the back.
My thought is hydrocephalus.
Sorry?
Slowly progressive hydrocephalus.
Yeah, so hydrocephalus does not appear within a few weeks. It's so I'm talking about something which is even more rapidly progressing.
Medication?
Sorry?
Medication? Medication.
Medication. Well, you know, if they started medication lately, yes, right. What else can do this? A person comes and then you don't know, you think about it, you say, let's do this test, and and come back next month or when I have an opportunity to see you again, and they come the following month and they are much worse within a month. This does not happen with the regular cases of mild cognitive impairment. This is, any suggestions? Can't hear. What happened to your microphone? You had a microphone on your table.
Maybe hormonal, the thyroid.
Maybe?
Hormonal, the thyroid function.
Thyroid. Again, thyroid dysfunction is important, and we measure it regularly in all the cases that I've mentioned. This is very important, like B12 and so on. But this does not cause rapid decline, except for a rare occasion that I will talk about in a minute. So I think one thing that that I'm sure you've heard about is autoimmune encephalitis. Autoimmune encephalitis may be paraneoplastic, maybe not, and this is something that can cause cognitive decline of rapid onset, sometimes associated with other features, but initially can be the only symptom. And this is something which is important because this is a curable condition. This is something that you can identify and cure if you give the right treatment. But you have to think about it. And also to verify this, anybody can say, what are you going to do in order to confirm a suspected diagnosis of autoimmune encephalitis? Nobody heard about autoimmune encephalitis. You have this patient with suspected autoimmune encephalitis. What are you going to examine to confirm or not the diagnosis? Who is talking? I can. Okay, microphone. Here's the chairman pointing at the person.
Thank you. Potassium-gated channel antibodies.
Yes. Yeah, I think that the important thing is to think about, when you think about it, to have an MRI, and the MRI will show what? What can show nothing, but can show what? You have a, take the microphone.
Hyperintensity in the limbic
Okay,
area.
so limbic, enhanced lesion, right. So this is an important thing. Also, you do a lumbar puncture, and autoimmune encephalitis, it's an encephalitis. So what do you see there in the CSF? What do you see in the cases of encephalitis in the cerebrospinal fluid? It's an itis, right? So autoimmune encephalitis. So it's an inflammatory lesion. If it's an inflammatory lesion, there should be cells there. So you should look. Okay, so you got on a certain number of patients, you did this, and some of them had this. They don't necessarily have to do it. One of the cases, you got the result that they came, the result of the CSF came, they have, this person had high tau level in the CSF. So what does it mean? If there is a high tau protein level in the CSF. Have you heard about tau? That's Greece. Anybody here from Greece? No participants from Greece who know what tau is? Anybody from outside Greece who can tell us what is the tau protein? So tau is an important protein in the brain. It's important because it occurs in all neurons. All neurons have in their axons tau, which is important for the tubulin, for the function of the axons. And if this tau is hyperphosphorylated, this is a reflection of Alzheimer's pathology. So if they have high tau level in the CSF, this can be a manifestation that they develop Alzheimer's disease. If the tau level is very high, what will it say? It's diagnostic of what? Somebody is running out. Mr. Chairman, can you stop them from leaving? Very high tau level. Have you heard of Creutzfeldt-Jakob disease? This is the most important thing. How much time do I have?
It's almost the time. I mean, we have more 2 minutes or so.
Okay, so what if this person comes and the person who joins him say, well, you know, he is not doing well, not remembering well, but not all the time. Sometimes he's better, sometimes he's completely normal, and then a few hours later, you cannot talk to him, and then again, doing well. What can it be? What would you suspect? Well, I would suspect that the person has some medication problem or some alcohol problem. So if they drink, and the spouse may not know or may not admit that the person drinks. So if they take some vodka and they don't function well, and then the vodka has a short half-life and they are okay again until they drink again. So fluctuating cognition is something that we should think about in this term. We should also ask, and I had it in one of my slides before, about their gait. And we should ask whether any person of that age, whether they fall a lot. And if the report comes back that they fall, that they tended to fall, what should we think about them? Why do they fall? So there are many things that can cause falls, of course, but one of these is loss of postural reflexes. This is perhaps the most important thing. And we should examine these people. Of course, we examine everybody, but in this case, we should examine more carefully the extrapyramidal symptoms to see if they have extrapyramidal manifestations. And if they do, then the reason for the cognition, they did not talk about their falls, and the extrapyramidal manifestations were really mild and not noticeable to them. But if we find them on examination, then what do we think about the underlying diagnosis? Not Parkinson, because when it is Parkinson, usually they don't complain first of cognitive symptoms. What is the situation in which they have Parkinsonian symptoms? Dementia with Lewy body, that's correct. So this may be the first manifestations of dementia with Lewy body. And again, this is important diagnosis. The disease will progress, but we have drugs that can help them. So these are some of the red flags that we should think about. And thank you very much. And you got the prize, so you can come to Madrid. Yes? All right. Thank you very much.
Thank you very much, Professor Korczyn, for this very attractive presentation of mild cognitive impairment and clinical diagnosis of cognitive syndromes.